Right, so this is the document of what we are talking about, atypical squamous cells of unknown significance. So what you do for that, if you get ascus, what you do is you test for high risk HPV types. If the test is positive, colposcopy is done. If the HPV test is negative, they go for routine follow-up. Then if the HPV test is not performed, we repeat the cytology in 6 months. If two negative test results are obtained, we return to routine follow-up in 3 years. If the result is as or worse, when we do the repeat cytology in 6 months, then we go for colposcopy. So in this 2 months, after 1 year, that may be the second cytology in the follow-up, she has still got ascus. Therefore, she needs colposcopy. But we don't do excision at the moment. We do excision only if the colposcopy report comes back as SIN2 or SIN3. So all the others. Now only for ascus we follow this principle. But if we have ascus H, that atypical cells of cannot exclude high-grade squamous, then we do colposcopy. DNA testing is HPV DNA testing is not included because ascus H or atypical squamous cells cannot exclude high-grade squamous intraepithelial lesion is associated with a high incidence of SIN2 and SIN3. Therefore, we don't go for DNA testing. Then if it comes as LC, that is low-grade squamous intraepithelial lesion, again we follow the same principle as if we do HPV testing, if HPV is positive, colposcopy. If the HPV test is not performed, repeat cytology in 6 months. If two negative test results is obtained, they return to routine follow-up. If the result is LC or worse on follow-up, they go over to do colposcopy. So ascus and LC are managed in the same way. Ascus H and HC are managed with colposcopy. Make it චූටි වෙනසක් ඇතුව මගේ SBA පොතේ තියෙනවා. So read that for the moment. There's slight difference in the new note and in the SPA book. Slight difference, but not a significant difference. So you can read that for more information. If you don't understand, read it. Because if it is ascus H and HCil, they go for immediate colposcopy. If it is LCil or ascus, they go for HPV DNA test. If the DNA test is positive, they go for colposcopy. If the DNA test is negative, we do two follow. Hello. Oh. අනේ මගේ හස්බන්ඩ් කිව්වේ නැත 1 o'clock නෙවෙයි 2:30 කියලා. ඔව්. අනේ මම හස්බන්ඩ් කිව්වා කියන්න කියලා. හරි නෑ. යන්නේ thank you very much. So if it is ascus or LCL, we have two options. We can do as HPV DNA testing. If it's positive, she goes for colposcopy. If negative, she goes for routine follow-up. If HPV DNA is not done, we do smears at 6 monthly intervals. If at any point the smears are positive, that is, if ascus or HCL is found again in the smears, they go for colposcopy. If at the end of there are two negative smears at the end of 1 year, they go for routine follow-up. So you can listen to this again, and then you can, if there's a slight adjustment, you can make it in your book. It's so simple, it's not difficult. To think it's difficult, it's not difficult at all. So going back to the document, here with the because there has been a positive result after 1 year, we have to go for colposcopy. A 34-year-old woman presents with a third-degree vaginal large cystosome. She wishes to preserve her fertility, but does not wish to conceive soon. If she wishes to conceive soon, if of you insert a pessary and ask her to conceive, insert a ring pessary and ask her to conceive. But now you can't do you can't correct this with a Manchester operation because it's a third degree prolapse. That means the whole uterus is out. Manchester operation won't work. So actually here we have to do a sacrohistopexy. It's a little too much for undergraduates, but anyway. Also, this finishes the this finishes the SBA questions. Now we have any questions from this? Any questions?
Madam, when do we use a ring pessary with the support?
And
When do we use a ring pessary with the support?
that pessary falls off, we can use it as support, right? Don't think about it. A ring pessary is enough. මේක මම හිතන්නේ මම පෝස්ට් ග්‍රැජුවේට් එකකින් ගත්ත එක. ඔයගොල්ලන්ට ඒවා කියලා දීලා නෑනේ. Then comment if you are no questions, we'll go for the true false one. They are also very informative. Primary dysfunctional labor begins in the first stage of labor. Usually it begins in the first stage of labor, at least in the later part of the first stage of labor. In the second stage of labor, also you can get, then you don't call it primary dysfunctional labor. Second stage of labor can be prolonged due to inadequate uterine contractions, but the term primary dysfunctional labor is used only when it begins in the first stage of labor. But remember, second stage also can become prolonged due to inadequate uterine contractions. Is caused by inadequate uterine contractions is correct. Is treated by amniotomy and oxytocin infusion. Yes, that is the first line management. If we call it primary dysfunctional labor, it indicates that labor is slow from the start due to inadequate uterine contractions. So most probably there's no other cause for obstruction, since they haven't told anything like that. Treated by with amniotomy and oxytocin infusion is correct. As long as there's no evidence of obstruction, as long as the pelvis is adequate, as long as there are no malpresentations which are incompatible with normal delivery, as long as the fetal heart rate is normal, as long as the mother is willing, we can start amniotomy and oxytocin infusion. Things that should be satisfied is no obstruction, adequate pelvis, no malpresentations incompatible with normal delivery, like brow presentation, into a posterior face presentation of transverse line. If the fetal heart sounds are satisfactory and the mother is willing, we can start amniotomy and oxytocin infusion. It doesn't occur only in primiparous patients, it can occur in any patient. Requires a cesarean section in the presence of a previous section scar, because if there's a previous section scar, then starting oxytocin infusion is a problem. Therefore, it needs a section. So a section is needed if there's any evidence of obstruction, malpresentation incompatible with normal delivery, inadequacy of the pelvis, uh, fetal heart rate problems, scarred uterus, and the mother is not willing. And there's severe maternal distress. The mother is very anxious and not willing or aware what women mean by maternal distress. If there's any evidence of sepsis, any evidence of impending rupture, mother is very anxious and not willing, then we have to go for section. Otherwise, in all the others, we go for amniotomy and oxytocin infusion. Replay this tomorrow and copy down the ones that I told what the hospital by contraindications, amniotomy and oxytocin, what I told copy down tomorrow. Secondary risk is caused by any thing that causes obstruction. So brow presentation, cephalopelvic disproportion, and shoulder presentation can cause secondary risk. Epidural analgesia doesn't slow the first stage of labor. Men to anterior face presentation can cause primary dysfunctional labor because the presenting part is soft and is treated by oxytocin infusion, but it will not cause secondary risk. Secondary risk is lack of progress in the presence of strong uterine contractions due to some form of obstruction to the forward passage of the fetus. ඒවා පොතේ හොඳට තියෙන SPA second එකේ. Immediate management of atonic postpartum hemorrhage requires resuscitation, therefore blood transfusion comes in there, requires intravenous infusion of oxytocin, ergometrin, per rectal means prostol, ඊළඟ එක දැනන් හිටියේ නැහැ. Uterine massage and bimanual compression. So we need resuscitation with IV fluids and blood transfusion, giving of oxytocin drugs, uterine massage and bimanual compression. Next step is balloon tamponade. Next step is insertion of a bleeding suture. So immediate management doesn't mean balloon tamponade and insertion of a bleeding suture. Then also in immediate management we can give tranexamic 1000. මේ වැඩ ඕසස් දන්නේ නැත්නම් නිකන් නමවල් කියලා වැඩක් නැහැ. As the ඔක්කොම පොතේ තියෙනවා. Tranexamic 1000 milligrams IV can be given as initial management, and also carboprof can be given if it's available. මේ ඔක්කොගේම doses ඔක්කො පොතේ තියෙනවා. මේවා දන්නේ නැතුව විභාගෙට එන්න එක. Next step is after giving oxytocin drugs, massaging and bimanual compression. Next step is balloon tamponade. Next step is bleeding suture. ඒගොල්ලෝ එක තැනකට ඇවිල්ලා එතනින් ආයෙත් අහන්න බෑ. There's oxytocin drugs are given. She's still bleeding. What is the next step? Next step is balloon tamponade. They can give it for SBA. Then they can come up to balloon tamponade and ask what is the next step. The next step is insertion of a bleeding suture. Or they can say, this woman is a multiparous woman who bleeding profusely in spite of blood transfusion and oxytocin drugs. Still, she's almost in a collapse state. What is the next step? What is the best management option? To perform a hysterectomy before she is moribund. Antepartum hemorrhage due to placenta previa causes fetal anemia. No, fetal anemia is only caused by rupture of vasa previa because she is only losing only the mother is losing blood. There is no blood loss from the fetus. Causes postpartum hemorrhage. If DIC occurs, causes postpartum hemorrhage is correct, but not due to DIC. It causes postpartum hemorrhage because of the large placental area, because the lower segment doesn't contract as well as the upper segment, and because there can be morbid adhesion of the placenta. ඔක්කොම පොතේ තියෙනවා බලාගන්න. ඔයයි මං හිතනවා මං කට බිම අතුල්ල ගන්න කොහොමද ඕගොල්ලන්ට කියනවට වැඩිය කියලා. කට බිම ඇතුල්ලුවත් ඕගොල්ලෝ කියන දේවල් කරන්න. Causes severe bleeding with onset of labor. Yes, it's because it starts recurrent bleeding with the formation of the lower segment. Because in the formation of lower segment, the uterus stretches. Then there's some separation of the placenta, but the greatest separation occurs during with the onset of labor, and then she will start severe bleeding when the placenta begins to separate. When the lower segment stretches, placenta begins to separate from the lower segment. That is why it's recurrent and severe bleeding, because the latest separation from the lower segment occurs with onset of labor when the lower segment stretches a lot. It's not always treated by immediate cesarean section. It's treated with immediate cesarean section only if the bleeding is profuse or she comes after 36 weeks. If the bleeding stops and there's premature fetus is prematurely carry out expectant management. In primary dysfunctional labor, A is correct, B is correct, C is correct. In secondary arrest, A is correct, B is correct, E is correct. Make in the primary dysfunction A, B, C, and E all are correct. Correct. මේ answers ටිකත් එක්ක මේ document එක answers එවන්නම්. Secondary arrest is caused by A is correct, B is correct, E is correct. Immediate management of postpartum hemorrhage, B is correct, D is correct, E is correct. In antepartum hemorrhage due to placenta previa, C and D are correct. In breech presentation, a footling breech cannot be delivered vaginally because for several reasons. One thing is a small presenting part. Cord prolapse can occur because it doesn't fit into the cervix. Prolonged labor can occur because it doesn't fit into the cervix. The foot can come out through a partially dilated cervix and stimulate expulsive uterine efforts, causing and the woman can start delivering, causing obstruction to the delivery of the head. So because of this dangerous condition, footling breech is always delivered vaginally. A footling breech can be diagnosed only after onset of labor, after about 4-5 centimeter dilatation. What is meant by footling breech is where foot is at the internal loss, foot is below the buttocks and is a presenting part at the internal loss. So footling breech cannot be delivered vaginally. Labor is induced if post-maturity occur. No induction of labor is little bit of a risky because strong contractions caused by the oxytocin agent can cause descent of the breech, but can cause obstruction of the delivery of the head if there's any CPD. Therefore, we don't recommend any oxytocin drugs to improve contractions or to induce labor in breech presentation. Luxus maneuver is carried out with the arms are flexed. No Luxus maneuver is carried out with the arms are extended. Pinard's maneuver is with to extend the legs is correct. If the legs are flexed, they can be just eased out. If the arms are flexed, they can be easily eased out. So Luxus maneuver and Pinard's maneuver are required to deliver extended arms and extended legs. Vaginal delivery is not recommended in preterm breaches. So only D is correct there. During labor and breech presentation, amniotomy is delayed till the breech is well descended. Yes, because otherwise cord prolapse can occur. We wait until the breech is well descended and well applied to the presenting part before doing an amniotomy. Breech extraction is carried out if fetal distress occurs in the second stage. It's wrong. I told you yesterday also. Breech extraction can be carried out only for emergency procedures, emergency delivery, and second operations. In no other situation can you carry out breech extraction for a second stage problem in singleton breech. 5 units of oxytocin is given intravenously after delivery of the head. That is correct for active management of the third stage. Intramuscular pethidine is given for pain relief is correct. Even epidural can be given with 0.625 milligrams. With a very low matter sure now, it is 0.625, the 0.0625. Among them it is 0.0625. Anyway, low dose, you don't have to know the dose. Low dose epidural can be given for pain relief. That is the best form of pain relief. Why? Because it prevents premature bearing down efforts. That's the best one. It doesn't impair bearing down efforts because it's low dose. But intramuscular pethidine also can be given. Oxytocin is not used to augment labor. If the first stage is prolonged, we do a cesarean section. දැන් මේ deep vein thrombosis ගැන අපි වැඩිය කතා කරන්නේ නැහැ. හැබැයි ඒක එන්න පුළුවන්. For God's sake, read the book of deep vein thrombosis. If a woman develops deep vein thrombosis at 36 weeks, she has to be given the therapeutic dose of subcutaneous heparin. So we give this. So in the previous one, during labor and breech presentation, A is correct, amniotomy is delayed, C is correct, that is for the active management of the third stage, D is correct, B and E are wrong. Woman who develops deep vein thrombosis of 36 weeks, the primary treatment is to give the therapeutic dose of low molecular weight heparin twice daily. මම ඒක හරි කිව්වට ඒක එච්චරම හරි නෑ because you don't give intravenous uncapsular heparin during labor, but we can give it for 48 hours postpartum. ඒක වැරදි. I will tell you the management that is wrong. මම අද උදේ තමයි Now, subcutaneous low molecular heparin 40 milligrams daily is the prophylactic dose. But since she has developed a deep vein thrombosis, subcutaneous low molecular weight heparin 60 milligrams twice daily therapeutic dose has to be commenced. Then 5 days after postpartum, you can turn on to warfarin after 5 days postpartum. Then you will stop low molecular weight heparin low molecular weight heparin at the onset of labor. You don't give unfractionated heparin during labor, but you can start unfractionated heparin 6 hours after delivery and continue for 24 hours. You can start low molecular weight heparin after 24 hours. So the therapeutic daily dose is 60 milligrams twice daily, stopping at the onset of labor. If we are really desperate, we can start unfractionated heparin 4 to 6 hours after delivery continue for 24 to 48 hours and then recommence low molecular weight heparin, we can convert it to warfarin from the 5th postpartum day. So C is correct, D is correct. Now maternal rubella is confirmed at a period of 8 weeks. How do you confirm maternal rubella? By the presence of IgM or fourfold rise of IgG. So when woman comes saying I've been exposed to rubella, you should do the, if you are not sure of the immune status, you should do the IgM and IgG. Presence of IgG in the first sample doesn't indicate infection because it could be due to immunity. But presence of IgM in the first sample indicates infection. Fourfold rise of IgG in the second sample done 3 weeks later, or rise of presence of IgM indicates an acute infection. So that is how you diagnose maternal rubella infection of compotatian. There's no falling of the antibody levels. So once we diagnose rubella, we cannot continue the pregnancy. Women should be counseled regarding germination. If we want further confirmation, the only thing that we can do is perform CVS for rubella specific DNA to confirm fetal infection. You can do that, but that is not really necessary because it's serologically IgM is present or there's fourfold rise of IgG. Then we say that the woman is infected, and since it's 8 weeks, the baby will be severely affected. The affected cannot be diagnosed by ultrasound scan because mainly auditory and neurological and ocular abnormalities which cannot be diagnosed by ultrasound scan. So therefore, we have actually counsel regarding termination. If the woman requests for further confirmation, then we can do CVS or rubella specific DNA. There's no immunoglobulin to prevent or treat rubella. Increased risk of Down syndrome in the first trimester. The screen, in other words, they are asking the screening test because versus increased risk of Down syndrome, perform some screening test. So analysis of self-repeated DNA, decrease of pregnancy-associated plasma protein, increased maternal serum beta-HCG, and ultrasound scan for increased nuchal translucency. These are the screening tests. Chorionic sampling is the confirmatory test. The drugs that are used of pre-medic, so here the A, C, D, and E are correct. In the previous question, only D and E are correct. Which of the following drugs are used for pre-medication before an elective cesarean section? What we use is domperidone, 10 milligrams.
Madam.
Oh,
Madam, one doubt regarding the previous question, madam. Madam, the cell-free fetal DNA, do we usually do in the first trimester or it is in the
we can
15th
do
week?
after 10 weeks.
Okay.
After 10 weeks, right? Not before 10 weeks. For rhesus, we have to wait till 15 weeks. All the others, for fetal sex, we can do after 10 weeks. But here the thing is analysis of cell-free fetal DNA is confirmatory for sex and the fetal blood group. It's still a screening test for Down syndrome. So what we give for pre-medication is domperidone, metoclopramide, and famotidine, cimetidine, or omeprazole. Omeprazole and famotidine are given at the rate of 20 milligrams. Domperidone and metoclopramide at 10 milligrams dose. Sodium citrate is given in the theater, so that is also correct. Ondansetron is not given. ELMA ondansetron can give up. Ondansetron is an anti-emetic drug. It's not a drug given for pre-medication for section.
Excuse me, madam.
Oh,
Madam, another clarification. Madam, do we offer termination for the rubella infection?
yes, that is the only treatment.
Madam?
ලංකාවේ කරන්න බෑ. ඒක හොඳ question එකක් ඔයාලේ මට ඒක කියන්න අමතකුණා. But here the wording is different. Women should be counseled regarding termination. Termination should be performed කියලා නැහැ. There's no other treatment for confirmed rubella infection. It can be confirmed by positive IgM or focal rising IgM. Okay? There's no other treatment. There's no other way of even assessing whether baby is seriously affected or not. ලංකාවේ කරන්න බෑ. ඒකයි wording එක එහෙම තියෙන්නේ. Counsel regarding termination.
Thank you, madam.
Primary amenorrhea with good breast development is found in empty cellular syndrome. No, empty cellular can pan hypopituitarism. Therefore, there will be no good breast development because there is no gonadotropins. Therefore, no is nothing to stimulate the ovaries to produce estrogen. Imperforate hymen, yes, because the hypothalamo-pituitary ovarian axis is normal. It's a structural defect. Mayer-Rokitansky syndrome, yes, because again it's a structural syndrome. Resistant ovary syndrome, no, because ovary has failed. There's no estrogen. Testicular feminization is the now we call it complete androgen insensitivity, yes. We just explained a few minutes ago. So B, C, and E are correct. This I explained a few minutes ago. So virilism occurs in congenital adrenal hyperplasia. Yes. XY gonadal agenesis. No. Now, what is this gonadal agenesis? XY or XX fetus in a XX or XY fetus gonads fail to develop. Because if they in XY fetus, if the SRY gene is absent, if you can understand, think about it. Otherwise, just forget about it. If XY and if the SRY gene is not functioning, the testes don't develop. So in an XX1 or a XY1, if the testis doesn't develop or if the ovaries don't develop, virilism cannot occur. Whether it's XY or XX, gonadal agenesis will have all female character. No gonads in XY male. Internal genitalia will be female. External genitalia will be female. So there's no virilism because there's no testis to cause male characteristics. Polycystic ovarian syndrome, you only get hirsutism, not virilism. Adenoblastoma of the ovary is correct. You get can get virilism. Cryptorchidism is yes. What is cryptorchidism? Is improper descent of the testis. That will definitely it's a male, so there will be virilism. So A, D, and E are correct. Congenital adrenal hyperplasia and adenoblastoma will be XX. E will be XY. Secondary hemorrhage. What is secondary hemorrhage? Where bleeding occurs after about 5 days of any surgery. Could be abdominal or could be vaginal. In abdominal is due to suffering of infected tissue. So there are the signs of infection like fever and vaginal discharge. And after 5 days, woman will start bleeding. It can occur due to infection of the wall after abdominal hysterectomy, or it can occur due to infection of the vaginal wound in vaginal hysterectomy. So it can occur after abdominal hysterectomy, so it's wrong. It's caused by sloughing of infected tissue, correct. It cannot be treated by ligating. The vessels are complete in a minute. occurs 7 to 10 days after vaginal hysterectomy is correct because administration of intravenous antibiotics is correct. Now, when you call about secondary postpartum hemorrhage, any hemorrhage occurring after 24 hours is called secondary postpartum hemorrhage. But secondary hemorrhage caused by surgery will occur only after 5 days. So it is due to infection and sloughing off of the infected tissue. Therefore, there's a lot of raw areas there. You cannot ligate the bleeding vessels. So, what is the treatment? First line treatment is to resuscitate, then send the blood and the other high vaginas of culture and ABST, start intravenous broad spectrum antibiotics to stop the bleeding by packing the vagina tightly, because there's no other way of stopping the bleeding, because we cannot ligate the bleeding vessels. Because if we try to ligate one, then vessels are not visible. Even to put deep metal sutures is not possible because it will cut through the tissues with bleeding. Which of the following complications cause abdominal distension and vomiting after hysterectomy? Cutting the bladder won't, because bladder is extraperitoneal structure. Most of the urine will drain through the vagina. Cutting the ureter, yes, because part will drain through the vagina. Most of the urine will leak into the peritoneal cavity. Retain foreign body, yes. Because this infection causes abdominal distension, vomiting due to peritonitis, bowel damage, yes. So these are all dangerous conditions. We should be very careful. If a woman develops abdominal distension and vomiting after hysterectomy, it occurs usually after 48 hours. But it can occur very soon after surgery, because all these can cause immediate symptoms. Non-contraceptives or combined oral contraceptives include induction of regular menstruation, testicular feminization syndrome, complete androgen insensitivity. It cannot, because we told a few minutes ago that woman doesn't carry uterus because she has a testis is producing AMH, therefore uterus will disappear. Induction of regular menstruation in women with hypergonadotrophic amenorrhea. Yes, what do you mean hypergonadotrophy? Where there is a problem in the ovarian failure. But I told you progesterone cannot cause withdrawal bleeding, but non-contraceptives or combined oral contraceptives can cause withdrawal bleeding. So this induction of regular menstruation, women with hypergonadotrophic amenorrhea, we can use combined oral contraceptives, but it's not the ideal method of treatment because the estrogen content is inadequate. Therefore, ideally we should use HRT, cyclical. But there's nothing, we can still use oral contraceptives also, so it is correct. Postmenopausal hormone replacement, මෙතන B එකේ for hormone replacement therapy in women with hypogonadotrophic amenorrhea කියවනම් වැරදි. Induction of regular menstruation කියවනම් හරි. Postmenopausal hormone replacement therapy වැරදි. මොකද මේවා කියන 30 mcg. ඒක මදිනේ. You have to at least give one or 2 milligrams of estrogen for this. So at least 0.625 milligrams of pectinal estradiol should be given, or 1 milligram, or even up to 2 milligrams. So this has only insert NCD, it's not in. Treatment of abnormal uterine bleeding in the absence of uterine pathology. Yes, it's just now we told it's a non-contraceptive. Treatment of endometriosis is here. Laparoscopy is performed in an infertile woman. To aspirate recycling in vitro fertilization. That is wrong. Because oocytes are aspirated vaginally under ultrasound guide. So that is wrong. Induction of regular menstruation in women with laparoscopy is performed. So in the previous question, B, D, and E are correct. Laparoscopy is performed in an infertile woman to aspirate oocytes in vitro fertilization is wrong. Because aspirated vaginal perform endometriosis is correct. Perform diathermy pancreas polycystic ovaries is correct. Remove submucous fibroid. No, any submucous fibroid cannot be removed through laparoscopy. Less than 5 centimeters in size can be removed by hysteroscopy. If it's more than 5 centimeters in size, it has to be removed by myomectomy, open myomectomy. Treat endometriotic cyst and deposits. Yes, laparoscopy is the best method to treat endometriotic cyst and deposits. Which of the following methods are used to induce ovulation in women with low FSH and LH levels? Initial treatment of promising citrate is correct. That's the first line treatment. Diathermy pancreas ovaries is only for PCOS, and there is no low FSH and LH levels. Moderation of exercise, yes, because sometimes in these athletes you can get low FSH and LH levels. Pulsatile administration of GnRH is yes. If the low FSH and LH is below GnRH levels with the problems in the hypothalamus, then we can use pulsatile administration GnRH. Treatment with FSH injection followed by LH is also correct. Because just a minute. නෑ ඒක වැරදි. Sorry ඒක වැරදි. Because LH කියලාම නෙවෙයි අපි දෙන්නේ. Treatment with FSH injection followed by HCG injection. LH තමයි අපි LH හැටියට දෙන්නේ. ඒක වැරදි. That's a trick. මමත් ඒක හරි කියලා දැම්මා උදේ. First line treatment is promising citrate, moderation of exercise levels. If they are undergoing CV exercise, that is also correct. If the lesion is in the hypothalamus, then we can administer GnRH. So yesterday I told you FSH and LH levels are low. Next thing is to see where the lesion is. So we do the GnRH levels, and we also do we do the GnRH levels, and we check the other pituitary hormones. So if it is due to hypothalamic problem, pulsatile administration of GnRH is correct. In hypergonadotropic azoospermia, that means the testis has failed. Hypergonadotropic azoospermia කියන්නේ testis has failed. Hypergonadotropic amenorrhea කියන්නේ ovaries have failed. Intrauterine sperm insemination is performed with donor semen. Yes, because hypergonadotropic azoospermia cannot be corrected much. Sperm count cannot be improved. Sperm count cannot be improved by treating with HCG and FSH injection. If it's hypogonadotropic, we can. But hypergonadotropic azoospermia is not treatable. Karyotyping can be performed to see why, what has happened. Testicular biopsies of no value in hypergonadotropic azoospermia. If testicular biopsy is only performed in normogonadotropic azoospermia to exclude obstructed lesion. Sperm count cannot be improved by any way. Cannot be improved by testosterone injections because the testis has failed. So the option is donor semen. Only treatment option is donor semen. If it is hypogonadotropic, we can start with treatment with clomiphene citrate for 3 months. If that doesn't work, we can improve the sperm count by giving HCG and FSH injections. During transvaginal scanning of an early pregnancy, a twin pregnancy cannot be identified till 7 weeks. It's wrong. If twin pregnancy can be identified from 5 weeks, whenever you can, as early as you can see a sac, you can identify twin pregnancy. In early pregnancy, we identify by counting sacs. If the CRL is less than 7 millimeters and the fetal heartbeat is not seen, scan is repeated in 7 days. If the CRL is less than 7 millimeters, anyway fetal heartbeat cannot be seen. Therefore, scan has to be repeated in 7 days. Even if the CRL is more than 7 millimeters, the first step in the management is to repeat the scan in 7 days to identify the fetal heartbeat. That is what the guideline says. So if the CRL is less or more, you repeat the scan in 7 days. Better result is more likely if the CRL is less than 7 millimeters because fetal heartbeat will not be seen until it's more than 7 millimeters. But the CRL is 7 millimeters and the fetal heartbeat is not seen. A good result may not be obtained after 7 days. But the first line management is to repeat the scan after 7 days. If the gestational sac is more than 25 or less than 25, again you have to repeat the scan in 7 days. If it's less than 25, positive result